Hi, this is Manos Brilakis from the Minneapolis Heart Institute and the Cardiovascular Innovations Foundation, presenting case 121 for the Manual of CTO Interventions. This is a case entitled the Gordian knot, for reasons that will become apparent shortly. The patient was an elderly man that presented with lifestyle-limiting angina despite maximal medical therapy and was found to have an RCA-CTO single-vessel disease. He was referred for PCI of the right coronary artery, chronic total occlusion. The RCA had a proximal lesion, a well-defined distal cap with tapered entry. The distal vessel, the PDA, and the posterolateral vessel were filling from epicardial as well as septal collaterals from the circumflex and the LAD respectively, and the distal vessel was of good caliber. This is the dual injection, looking at the four characteristics of the CTO. Proximal cap is well defined, there's actually a wire there right now. The length is approximately 30 millimeters from the distal RCA to the PDA PLV bifurcation. The distal vessel is not very well visualized from the contralateral injection, but we can see the PLV as well as the PDA. And finally, there are both septal collaterals as well as an epicardial collateral that is fairly tortuous and does not seem appropriate for the retrograde approach. Therefore, our plan was to start with antegrade wire escalation. If that didn't work, attempt retrograde through septal collaterals, and if that failed, then use antegrade dissection reentry. This was the least favored approach because it appeared that we had a bifurcation of the PDA and the PLV at the distal cap, and we didn't want to lose any of those branches in case antegrade dissection reentry was used. We used right radial and right femoral access. The right radial, or the radial in general, is actually used increasingly in CTO PCI. In the Progress CTO registry, it was used in 67% of cases recently, a remarkable increase over past years. We tried to engage, however, the left main from the right radial, which was unsuccessful, and that is why we converted to bifemoral access and tried to obtain the left common femoral access. We cut access, cut the micropuncture wire, and then advanced the micropuncture kit, the wire. But then, when we were trying to advance the micropuncture dilator to exchange for the O35 wire, the dilator, instead of getting into the artery, actually kinked the wire and stayed outside the vessel. This is actually a different patient, but illustrates what happened in our patient. This is the needle with a micropuncture wire into the common femoral artery, right in the middle of the femoral head in a good spot. And here, this is the micropuncture dilator, which instead of going inside the vessel, actually has stayed outside and has also kinked the micropuncture wire. And that's exactly what happened in our patient. And the risk here is that if this is not recognized, one may think that the dilator is in the vessel and try to exchange for the sheath, and that's going to lead to wire position loss and bleeding, causing either a hematoma or even worse, even a retroperitoneal hematoma. So recognizing this kinking of the micropuncture wire, although this can happen even with a 0.035 wire, is critical to prevent access complications during femoral access. How can we solve the problem? One approach would be to pull the wire back and then cut the kinked segment and then advance another micropuncture dilator, but unfortunately the problem was that the remaining wire length was not enough to advance the full micropuncture dilator. So to solve this problem, we actually took a 6 French sheath and cut a small segment of the dilator of that sheath and used that over the 018 wire to get into the vessel, remove that wire, and inserted an O35 wire over which we were then able to advance a sheath. And this is what came out. This is the kinked wire fragment, and this is an illustration of getting the sheath and then cutting the distal portion of the sheath and using that over the remaining part of the micropuncture wire to get into the vessel and then exchange for a 0.035 inch guide wire. And we actually called this approach cutting the Gordian knot after Alexander the Great's story. This was in a city called Gordian in Asia, and there was a knot called the Gordian knot that was extremely hard to untie, and the oracle had it that whoever was able to untie this knot would become the ruler of Asia. Alexander the Great came in and instead of untying it, took his sword and cut the knot, which actually then led him to become ruler of large part of Asia. Moving on with the case, we finally have access in both femoral arteries. We engage the right coronary with an AL 0.75, providing good support. The left main was engaged with a 375 EBU. And using a standard microcatheter, Corsair Pro with a Pilot 200, we were actually able to cross into the distal trulumen. We placed two drug-eluting stents that were post-dilated up to 3.0 and 3.25 millimeters, and that restored antegrade flow. However, unfortunately, that led to occlusion of the right posterolateral vessel, which was a fairly sizable vessel. So to regain flow into this vessel, we used a dual-lumen microcatheter, TwinPass Torque, and a Fielder XTA, and that did advance into the right posterolateral vessel. Flow was restored after balloon angioplasty, and then after placing one additional drug-eluting stent, we did have a nice final result with T3 flow both in the PTA as well as the posterolateral vessel. So two lessons from this case. The first one is how to recognize and treat kinking of the access wire, whether this is a micropuncture wire, as in our case, or an 035 sheath wire. The key there is to understand if there is any resistance to advancing the micropuncture dilator or the sheath. Understand there may be a kinking and try to perform fluoroscopy. By doing fluoroscopy, one will detect the kink. And the question is how to fix it. And one approach that we used in this case was to pull back the kinked portion of the guide wire, cut it out, and then use a fragment of a dilator from a regular sheath to go over the remaining portion of the guide wire and then get back into the vessel and then exchange for an 035 wire. Actually, once exchanging for wires, it's good to use a stiff guide wire to facilitate the subsequent sheath insertion. The second point of the case is what to do in case of losing a major side branch. In this case, this PLV was a really large branch. So maintaining flow in both vessels is critical, both for acute but also for long-term patency and minimizing restenosis and improving relief of symptoms. And this can be facilitated by using a dual-lumen microcatheter over the guide wire that has crossed into the distal trulumen. Thank you.